So I'm going to break down the talk into three sections in essence: benign lesions seen in a general population, malignant lesions seen in a general population, and then lesions at patients who are at risk for developing HCC. I think it's really important when you approach a focal liver lesion to think about what type of patient you're imaging. So to start with, there's a bunch of benign hepatic lesions that we're all very familiar with. Obviously, there's cysts. This is a nice example of a hemorrhagic cyst in a patient who has additionally adjacent to it benign fluid cysts, so T1 hyperintensity intrinsically from the blood products, and you see the rim of hemosiderin being dark T2 on the T2 weighted images. In addition to just solitary cysts, you can get patterns of cysts in the liver. On the image here on your left, we have the classic biliary hamartomas, which are small sub-centimeter cysts that are diffusely distributed throughout the liver, von Meyenberg complex. And then you also have groupings of cysts associated with polycystic liver disease. These are benign appearing cysts as well, but they're more regular appearing and clustered throughout the liver, obviously associated with polycystic kidney disease as well. Cysts can also come in other distributions. For example, with peribiliary cysts, you can get cysts along the bile duct portal triads, and these are benign. They will not fill when you inject with ERCP, as they do not communicate with the bile ducts, but they're called peribiliary cysts. In contradistinction to that, you have Caroli's disease, which Ben touched on. This are also cystic structures that go along the length of the bile ducts, but these will opacify when you inject with ERCP, and you have the classic central dot sign, which is the portal radicals that are going through the cystic dilated bile ducts. So Caroli's disease, these will develop and have risk for cholangiocarcinoma in their life compared to peribiliary cysts. Okay, and obviously, can't forget cystic malignancies. We'll come back to this again, but there are certain types of tumors, ovarian, mucinous colorectal cancer that will metastasize with cystic metastases. These can be mimicking of normal benign appearing cysts in the liver. And then we have biliary cystadenoma, cystadenocarcinomas. These are somewhat difficult to distinguish between the benign cystadenoma and then the malignant cystadenocarcinoma. There are a couple of findings that may suggest that if you have a large mass component or chunky calcifications, that can suggest the adenocarcinoma, but you really can't come down hard on that. That's something that your pathologist will determine for you. So these are often resected, the biliary cystadenomas. Hemangioma is obviously the most common benign cysts in patients. They classically have the peripheral discontinuous puddling that slowly fills in and follows blood pool once it completely enhances. So discontinuous peripheral puddling fills in, follows blood pool, hemangioma. Most of these are very easy to diagnose, although some atypical appearance of hemangiomas can be a little confusing. For example, here you have a large giant hemangioma that has central clot. The central clot will not fill in on delayed imaging. You can see here on the 10-minute delay that the peripheral component is filling in with contrast, but that clot will never fill in. And here you can see the discontinuous peripheral puddling seen on the portal venous phase. On diffusion, you can see that there's high T2 signal peripherally, like you would see in a normal hemangioma, right? Hemangiomas are going to be very bright on T2 weighted imaging, whereas that central clot will have dark signal, okay? Then we have the flash-filling hemangioma. These are going to be the toughest probably to distinguish from other lesions, particularly in a cirrhotic liver, the flash-filling hemangioma. These will, here on an early arterial phase, you can see the flash-filling hemangioma enhances very quickly and becomes homogeneous during the arterial phase, but will persist in the portal venous phase in delayed phases. And also note that you can see a THID, a vascular shunt associated with it, which is very commonly described with hemangioma. So if you see a lesion that has a shunt, you should be in the back of your mind thinking, hey, maybe this is a hemangioma, and then obviously follow it through to the portal venous and delayed phases. This lesion becomes a big issue with hepatobiliary agents, which we'll talk about a little bit in a couple slides. Okay, so here's an example of a large hemangioma as well. Here's atypical filling. This is a hemangioma that's filling in from one side instead of the peripheral discontinuous surrounding. The periphery of the lesion, here we have enhancement coming from one edge of the lesion towards the other edge. So there can be other atypical filling patterns of hemangiomas. But this, you can see, has a very, very bright T2 signal, which is very characteristic of a hemangioma. Something that may mimic a hemangioma, which is very rare, is pileosis hepatitis. So this is a not malignant tumor, but a tumor that can cause disease because it can replace your normal hepatic parenchyma, causing liver failure. It's associated with AIDS and anabolic steroids, but it also has this sort of puddling progressive enhancement, although it's not always peripheral, and it seems to replace the hepatic parenchyma. So in the right patient population, you could think of pileosis hepatitis, but this would be if you see something very atypical and a giant hemangioma, something that you would consider to be a giant hemangioma, you may want to consider pileosis hepatitis. The same disease actually, abscess. So abscesses are another thing in cystic lesions in the liver that are very difficult to distinguish sometimes from other lesions. One of the really good take-home findings to distinguish an abscess from things like a metastasis is the cluster sign. So if you see multiple adjacent cysts, so here's a lesion, and there's multiple cysts within this lesion, that's a clustering of multiple adjacent abscesses that are growing together and coalescing into a single large lesion. That's very suggestive of an abscess. You can see here there's multiple T2 bright lesions, nodules adjacent to each other. Here you can see that they're rim enhancing post-gadolinium or post-contrast, and this is a cluster sign indicating that this is likely an abscess. Obviously, if you see air, that's going to be really hammer home to diagnose an abscess, but it's very uncommon. Only in 20% of hepatic abscesses will you actually see air. And also the enhancement pattern in the abscess is there's a lot of fibrous tissue and inflammatory tissue. You'll have progressive enhancement with an abscess. Here's an example of a pyogenic abscess. You can see there's multiple cystic regions within this lesion. On T2 wave image, you can see here there's a little fluid in regions there. In this lesion, you can see a periphery of T2 bright tissue. This is the inflammatory component that does not enhance on the earlier arterial phase. And as you go out to a 5-minute delay, that inflammatory fibrous tissue is starting to collect contrast and becoming hyperintense in the delay. So we're progressively enhancing instead of washing out. So the multiple cysts, cluster appearance, progressive enhancement should make you think of an abscess instead of a focal metastasis or a primary liver malignancy. Fungal abscesses, this is really more important to consider your patient population. Obviously, if you have an immunocompromised patient, then you should be considering a fungal abscess. So with the fungal abscess, you're going to see multiple small punctate hypoechoic or hypodense T2 bright lesions that are going to be consistent with a fungal abscess. This one here is in a patient with a lung transplant who's obviously immunocompromised. Going to other benign lesions, we have things like focal fat. Focal fat is actually a big mimicker in the liver. You have to be very careful when you're thinking about focal fat, particularly on CT where you don't have your in and out of phase imaging to sort of save you from miscalling focal fat a focal lesion. So here's an example of a geographic or a lobular fatty infiltration of the liver. If you can imagine that there'd be a nodule that just has fat, it will definitely look like a metastasis. So it can come in multiple distributions, diffuse throughout the liver, which is probably what we see most commonly, nodular, geographic. Classically, they'll be along the falciform ligament or in the gallbladder fossa, and then the MR is really the key to making this diagnosis, where you're going to lose signal intensity on the atophase when you compare to the in-phase images. Here's an example along the falciform ligament. You can see on the water reconstruction, this is using a Dixon 2-point reconstruction, that you have loss of signal in the water, and in the fat reconstruction, you see that there's fat there. So this is a nodular area, triangular, wedge-shaped, classic appearance, classic location for focal fat. We would mistake this for a lesion, but there are other lesions I'll show you in a sec that can mimic a focal hepatic lesion. Here's a case that was very difficult. So this is actually hemangioma. Let's just get this out. So T2 bright, peripheral enhancement, progressively fills in and stays with blood pool throughout all phases of imaging. But over here on T2, you can see there's a region that's dark on T2 that doesn't enhance very well and stays hypodense or hypointense throughout all phases of imaging. And there does seem to be some arterial enhancement here on the early arterial phase. And the question is this a focal lesion or is this focal fat? And it was very difficult because there's also a THID associated with the hemangioma, which is making this region here look like it's hyperenhancing. But the one telling characteristic that's really key in terms of determining focal fat that's large like this in a lobar distribution is that vessels are going to traverse through your focal fat. So when you see vessels going through a mass, you should be thinking of something like focal fat. HCC metastases are going to displace vessels and have mass effect, whereas focal fat won't. Okay, so it's very helpful to distinguish things like focal fat. And at our institution, people were concerned enough about this being a mass that they actually ordered a sulfur colloid study, and this didn't help because it didn't take up sulfur colloid, so people thought it was a focal mass, right, because the fat's replacing the functional hepatocytes, it's mimicking a mass again on sulfur colloid, not helping you in your diagnosis. So it's very important to think of focal fat when you're interpreting these images. Another flow-related disease is the hot quadrate sign. You can see here, this is internal mammary artery coming down, feeding this quadrate lobe of the liver with early arterial before portal venous enhanced flows coming in. Hot quadrate sign, obviously we talk about this frequently in nuclear medicine, but you can also see it oftentimes on the arterial phase in patients during CT examination, and oftentimes there may be focal fat or focal fatty sparing associated with this area. So if you're looking at a portal venous phase study, you may see hypodensity associated with focal fat due to the differences in blood flow, portal versus arterial source of blood. Here's an example of focal fatty sparing, the opposite of focal fat. So this is a very fatty liver, as you can see. It's very low density compared to the spleen. And there's this one area here along the portal region, periportal region, that it looks like it's an enhancing mass in the periportal region, but really this is just focal fatty sparing, and the patient has diffuse hepatosteatosis. MR, this would be very obvious. You would just look at your in and out of phase. You'd see signal loss throughout the whole liver, whereas this region would retain signal in your out of phase compared to the in phase. Nodular fatty sparing. This is a patient who has multiple, what look to be T2 bright lesions throughout, and you can see here on the in phase there's focal defects in signal and throughout the liver, but when you go to the out of phase, you suppress all of the background fat, everything disappears because it's nodular fatty sparing, mimicking diffuse metastases. This happened to be a patient with breast cancer where they were worried because on their T2 weighted imaging of the breast, they saw down the liver all of these bright T2 signal intensity lesions. This is just normal hepatic parenchyma where the adjacent fat was saturated out in a fat-satted T2 mimicking diffuse hepatic metastases. Okay, let's get down to the more interesting subjects of focal nodular hyperplasia. Okay, so FNH, we know the patient population typically in young women who are taking oral contraceptives. There's a classic appearance. They're arterially hypervascular. They become isointense in portal venous phase. They have a lobulated appearance, and then they have this scar septa that go throughout it. And then historically, you might use sulfur colloid to image it because FNHs contain functional hepatocytes that are going to take up the sulfur colloid, and that's a little different now. So here's a classic appearance of an FNH with a typical extracellular contrast agent on MR like Omniscan, Magnavist, Gatavist. Here on the arterial phase, you can see lobular, bright arterial enhancement. It becomes more isointense to adjacent hepatic parenchyma during the portal venous phase. And on the delayed phases, as you go further out in the delayed phases, you'll see that the scar, the central area that's non-enhancing initially, will start to collect contrast as it contains fibrous tissue, and that correlates well with your T2 weighted imaging, which is bright on T2. So this is the classic appearance of an FNH with extracellular contrast agents. And that obviously leads us to the topic of hepatobiliary agents. Now that we have Eovis, which was approved in 2008, 2009, hepatobiliary agents are much more commonly used to evaluate these focal lesions, particularly in young women. These agents are taken up by hepatocytes collected in normal hepatic parenchyma, so lesions that don't have or don't contain hepatocytes are going to be dark compared to the adjacent hepatic parenchyma. So they're incredibly helpful for things like metastases, and also on the opposite side, things like FNH. FNH contains hepatocytes. It's hyperplasia of hepatocytes, so it's going to take up Eovis, and it'll help us distinguish FNH from things like metastases or adenomas. Okay, there's two agents out there that you could use. Eovis is the one that most people use because so much of it is biliary excreted that we can do our hepatobiliary phase at 20 minutes, although there are papers and groups that will use multi-HANCE. This is taken up more slowly, and there's a much smaller fraction that has biliary excretion, so your hepatobiliary phase is actually acquired after the patient comes off the scanner 1 to 3 hours later. So you'll bring the patient back if you need to acquire a hepatobiliary phase. It can be very difficult in a private practice in terms of workflow, but there are hospitals that use this. So here's an example of an FNH with hepatobiliary agent. You can see here you get this beautiful early arterial feathery lobular enhancement. On the late arterial phase, it's already becoming isointense to the adjacent hepatic parenchyma. T2, the scar is bright. The lesion, this one actually is slightly hyperintense to the adjacent hepatic parenchyma, but typically it's more isointense. And on the hepatobiliary phase, you can see that the lesion is isointense in areas that are slightly hyperintense to the adjacent hepatic parenchyma. So this is your hepatobiliary phase classic appearance of an FNH. One thing I'd like to point out is oftentimes we'll use EOVIS to evaluate for hepatic metastases in patients who are getting chemotherapy for rectal cancer, neuroendocrine tumor. And those chemotherapies are oftentimes hepatotoxic, and so you actually develop other lesions that can mimic mimic a metastasis. So here you have an early arterial phase, you have an arterial enhancing lesion. This looks like a neuroendocrine metastasis. Portal venous phase, it becomes isointense. It's slightly hyperintense on T2. And on the hepatobiliary phase, which it's right here, I don't know if you can appreciate this, a little rim of hyperintensity, and centrally it's hypointense. Sort of looks like a Met, right? Is it becoming hypointense in the hepatobiliary phase, arterially hyperintense? But really what this is just focal nodular regeneration, or FNH, in a patient with chemotherapy who has hepatotoxicity, and it has this classic rim of hyperintensity that can sort of mimic a metastasis. So FNH in patients with chemotherapy can really mimic a metastasis, particularly in neuroendocrine patients who will have arterial hypervascular metastases. Okay, adenoma, the other correlate to the FNH. So adenomas, obviously similar patient population in some cases, right? Women with oral contraceptives, but it can also be associated with men who are taking anabolic steroids or glycogen storage disease. The key here to a certain extent is hemorrhage and the fact that they contain fat. They can both contain macroscopic and microscopic fat. So macroscopic fat, right, you're going to see the NJ ink artifacts surrounding a lobule of macroscopic fat. Microscopic fat is going to look at like signal loss on your adaphase, so they're going to have slightly different appearances. Just keep that in mind. So here's a classic adenoma, arterially hyperenhancing on CT. On adaphase, this is a little bit of a tricky. This is a patient who has a very steatotic liver, so it's actually focal fatty sparing compared to the normal liver. So when you look at the in-phase, adaphase, you're losing signal from the adjacent parenchyma. This lesion is actually fatty sparing. On the hepatobiliary phase, though, it's hypointense, right? Not like an FNH, hypointense, and obviously it's arterially hyperenhancing on the MR arterial phase, okay? Adenoma. It can also have the focal fatty or fatty sparing associated with it, something to keep in mind. So I think with adenomas, one thing that really confused me when I was in training was there's a very varied appearance of adenomas, like I just described. And one way to keep track of this is to remember that adenomas have recently been broken down in subtypes. And when you think about the subtypes, for me, it helps me interpret these images. So the first type is the most common, the inflammatory adenoma. This might be what we're most commonly used to. This is oftentimes a woman has a risk of bleeding and has a risk of malignancy. But the imaging is pretty characteristic, okay? It's going to be bright on T2, and it's going to be very arterially hyperenhancing, okay? So arterial vascularity, T2 bright. Okay, these ones have risk of malignancy, oftentimes in women, risk of bleeding. The other type, this one only occurs in women and is usually associated with contraceptive uses. Okay, this lesion, I don't know if the actual names of it really matter, but just remember these three categories. This lesion has no risk or minimal risk of bleeding and really no risk of malignancy. So very different management for this type of lesion, different imaging. This one contains fat. This is the one that's going to be microscopic fat that's going to loss of signal in the anaphase. You're going to have very mild arterial enhancement compared to the inflammatory, which will be brisk arterial enhancement, and it will have much more mild T2 hyperintensity. Okay, very different imaging characteristics, different patient management. Then you have the beta-catenin ones. These are much more aggressive, higher risk of malignancy. There's no really good characteristic. These are so heterogeneous of a type of population of lesions. But they occur in men most commonly, hormone administration, glycogen storage disease. So this is a different patient population that's going to develop these lesions. So here is the classic inflammatory adenoma, very bright on T2, brisk arterial enhancement, hypointense in the hepatobiliary phase, does not contain fat. Classic inflammatory adenoma in a patient who this one does have a mild risk of malignancy. Okay. So now let's go on to malignant lesions in the liver. So malignant lesions, metastases, I think you're all familiar with metastases. You can have calcifications in the MET here. Like this is a patient with mucinous colorectal metastases. You have cystic lesions, hypervascular METs like with neuroendocrine tumor, renal cell carcinoma. Classically, obviously, the hypovascular METs from breast cancer, colon cancer, and then you can also have obviously T1 bright mets from melanoma and other miscellaneous metastases. Here's an example of a metastatic carcinoid tumor. Arterially hypervascular, becomes hypointense in the portal venous phase. You can see it's very cellular, high signal on the high B value image, and it becomes hypointense in the hepatobiliary phase. So this is how you would use EOVIS. And here you can see EOVIS is very, very good at seeing very small lesions that you would miss on the normal arterial dynamic contrast enhanced images. So EOVIS or hepatobiliary imaging can be helpful with metastases. And then I have a little bit on cholangiocarcinoma. I know Ben touched on this, and I'll try to focus on sort of the peripheral nodular cholangiocarcinomas, obviously the at-risk patients that Ben mentioned. Classically, you have rim early enhancement, and then the center will fill in and have delayed enhancement centrally. So you have this target sign appearance. You have capsular retraction and biliary ductal dilation. So here's a classic example. You have ductal dilation associated with the lesion, capsular retraction. You have this peripheral component. You can see it on the T2 weighted imaging, and on the ADC it's dark. So this is the cellular peripheral component that's going to enhance earlier on the portal venous phase, and then on delayed phase, the center is going to progressively enhance into the fibrotic core. And the central core is going to have bright signal on your diffusion because it's not as cellular as a peripheral core. So you have a target appearance in a peripheral cholangiocarcinoma. Okay, it's not classic. You couldn't hammer down on this being a definitive diagnosis, but the target appearance should definitely bring to your mind a cholangiocarcinoma. Okay, here's a mass-forming cholangiocarcinoma that's much harder to image. You see the associated ductal dilation. You can see that it has poor enhancement, but it's slowly filling in centrally. And the use here of hepatobiliary imaging is great. As you can see, you can really delineate the margins of this tumor very well with hepatobiliary agents. Oftentimes, if you're using an extracellular agent, these more central lesions can be very difficult to determine where the edge of the lesion is and where the normal hepatic parenchyma is. Okay, and here it is with the extracellular gadolinium like Omniscan. It's very hard to distinguish where the periphery of this lesion is compared to a normal parenchyma and lesion that you can see very well with hepatobiliary agents, and this is with PET. Classic in tumors, Ben said, you see the dilated ducts, progressive enhancement, and you can see on T2 you have the flow void of the portal vein, but there's this T2 bright tissue that slowly enhances around the portal triads in the periportal region. Fibrolamellar HCC, again, patient population here is key. This is another lesion that has a scar with calcifications. There's obviously a differential for patients who have a scar. FNH, hemangioma, cholangiocarcinomas can all have scars. Conventional HCCs typically don't have a scar, and you would think of them in patients with risk factors, which we'll talk about in a second. Here's another case of fibrolamellar HCC, central scar in another case with fibrolamellar HCC. It's sometimes difficult to come down to a specific diagnosis, but in the right patient population, 20s, male, with a large focal mass, you should be thinking of a fibrolamellar HCC. Epithelial hemangioendothelioma, these have this target appearance when they are nodular like this. So you'll have a intense rim followed by a hyperarterial enhancing rim, and centrally it doesn't enhance very strongly in the arterial phase, and then that fills in on your 5-minute delay. Again, another appearance of a target sign. So this would be in your differential for a cholangiocarcinoma or maybe something like a hemangioma. Here's a different form. There's a diffuse form of a hemangioendothelioma that is typically peripherally based, hypodense on CT. These are very rare, unlikely to see it very often, but something to keep in mind if you see a regular peripheral lesion, obviously it will be hyper-metabolic on FDG PET. So let's go to at-risk patients. So at-risk patients, this is probably the most important thing with liver imaging is knowing your patient history. Is this patient at risk for HCC? So obviously we know the populations that are at risk for HCC, Hep B, Hep C. The key here is Hep B, you get HCC in the absence of cirrhosis, where Hep C, typically the patients will develop cirrhosis by the time they'll develop HCC. I want to focus a minute here on the difference between a regenerative nodule and a cirrhotic nodule. I think these terms, I was confused about them for a long time, are very confusing in the community. We oftentimes use the term regenerative nodule to describe all of these background nodules in the liver that all look the same. Okay, so the terminology that people are trying to use now is that these are cirrhotic nodules. Cirrhotic nodules are all those nodules you see that all look identical and make up the background of the liver. So that's what we use the term cirrhotic nodule for. Regenerative nodules is sort of saved for nodules and entities like Budd-Chiari, where you get regenerative nodular hyperplasia. Whereas in the liver, these actually aren't all regenerative. There's degeneration going on, and much more. If you go on pathology, they're very different than a regenerative nodule. So we're using the term cirrhotic nodule. Here's an example of cirrhotic nodules. It's usually T2 dark, slightly T1 bright. They all look sort of homogeneous in terms of enhancement pattern. This is pre-T1, and then portal venous phase. And obviously your HCC is brighter on T2, is dark on T1, washes out in the portal venous phase. So this is an example of a lot of cirrhotic nodules with an adjacent hepatocellular carcinoma. Now, the term dysplastic nodule is different. Dysplastic nodule describes a single nodule. You have a sea of regenerative nodules, or cirrhotic nodules. I'm making a mistake myself. A sea of cirrhotic nodules. You have one nodule that stands out that's different. It can be different in any way. It can be different in size, fat content, iron content, enhancement patterns. If it's different in any way that it distinguishes itself from the background cirrhotic nodule, this is then termed a dysplastic nodule. And it's really up to pathology to determine whether or not that's going to be a low-grade dysplastic nodule, which means that it has no cellular atypia, or if it's a high-grade dysplastic nodule and it does have cellular atypia. There's a couple features, like if it contains diffuse microscopic fat that suggests a high-grade dysplastic nodule, if there's atypical enhancement patterns. But in general, dysplastic nodule is just a single solid nodule that's different from the adjacent background cirrhotic nodules. We term that a dysplastic nodule. Here's an example of a siderotic nodule, which is a subset of a dysplastic nodule. We have a single nodule that's different than the background cirrhotic nodules here. It's intrinsically T1 hyperintense and it's T2 hypointense, and it doesn't really enhance arterially and stays slightly hypointense in all phases. This is a siderotic nodule, and all you really would need to say is that's a dysplastic nodule, right? This is a dysplastic nodule. But siderotic nodules don't have malignant potential, so the containing fat is significant in that it indicates benignity of a lesion for a cirrhotic nodule compared to other types of dysplastic nodules. Here's another siderotic nodule, large, T1 hyperintense, T2 dark, doesn't really have any suspicious enhancement features to be concerning for HCC, except size here is becoming an issue where you would then be concerned and maybe want to do something about it. But this will not be well treated by TACE because there's no arterial hypervascularity. Here's another dysplastic nodule. You can see it here, T1 intrinsically hyperintense, T2 dark. Hepatobiliary phase, it's hypointense in the hepatobiliary phase. You don't see anything particularly on arterial phase enhancement. What do you do with this in the hepatobiliary phase imaging? This would be one that would be at higher risk to become HCC, but it's still a dysplastic nodule. There's no indicating that this nodule at this time is HCC. The literature just suggests this has a higher chance of conversion compared to other types of dysplastic nodules when they're hypointense on the hepatobiliary phase. Here's a typical appearance of hepatocellular carcinoma. Subtle arterial hyperenhancement becomes ISO on the portal venous phase and then washes out here on the delayed phase. This is highlighting the fact that delayed phase has a higher sensitivity for washout appearance. So delayed phases can be very useful if you want to increase your sensitivity for hepatocellular carcinoma. But washout appearance, arterial hyperenhancement are the classic appearance of HCC. I'm a big proponent of LIRADS, as is Ben. So LIRADS is a system that was developed to help you characterize lesions consistently across your site so everyone says things are the same risk of malignancy instead of there being differences between interpretation. And the key of LIRADS is all in this table here. So all that other stuff is all not that helpful, but this table is really key. So size is important, arterial hyperenhancement is important, washout appearance, and then this term capsule appearance, which I'll show you an example of, and then threshold growth help you determine between LIRADS 3, which is an intermediate lesion, up to a LIRADS 5, which is a definite HCC. So these criteria are important for transplant list, OPTN criteria to determine what is HCC in terms of treatment for patients for transplant. That I did not expect. Okay, there we go. Nope. You know what is happening? There we go. So LIRADS, major criteria. Here's an example. You have an arterially hyperenhancing lesion. Actually, here's an example of a washout appearance, so on a portal venous phase, and then capsule appearance. Capsule appearance can only be described in a portal venous or delayed phase. You can see there's a rim of hyperenhancement that surrounds your nodule. Now, post-TACE, you can get capsule appearance. Capsule appearance post-TACE does not indicate any risk of malignancy. It's a common appearance post-TACE, so don't misinterpret capsule appearance post-TACE as being indicative of HCC. It's only in a lesion that is solid and pre-treated that you would be able to call a capsule appearance. Other ancillary criteria that are used in LIRADS, things that are T2, mildly T2 hyperintense, things that restrict on high B-weighted diffusion imaging, nodule appearance. So here's a large dysplastic nodule with multiple focal hyperenhancing lesions in it. So these are multiple foci of hepatocellular carcinoma within a dysplastic nodule, so nodule appearance. Also, if it contains fat, you can see here in phase, it loses signal in the out of phase. So there's diffuse microscopic fat throughout a lesion. This is suggestive of HCC. So these are minor criteria. Minor criteria can't help you get to LIRADS 5 definite HCC. So in the transplant list, I think this is an important thing to consider. We all know transplant criteria, right? If you have up to 3 lesions that are 1 to 3 centimeters or 1 up to 5 centimeters, they make transplant criteria. The only lesions that count here are LIRADS 5 lesions, okay? So if you have a bunch of things that maybe THIS you're suspicious of, but they don't make the criteria for LIRADS 5, then they come down and they're not LIRADS 5, so they don't bump you into transplant. And the thing I want to point out is one of the keys here is to get your patients into the transplant criteria. You don't want to say there's 20 things that are maybe HCC, that's multifocal HCC, and then they can't be transplanted. You instead want to say, hey, there's one of these that has all the criteria to be LIRADS 5, that's HCC, then there's a bunch of LIRADS 3 lesions, right? Because then that makes the patient, they can go to the board to get reviewed to see if they qualify for transplant. And in the same way, you don't want to overcall too many lesions to bring them out. Does that make sense? Here's an example of portal vein invasion with infiltrative HCC. Infiltrative HCC can be very difficult to diagnose because there's no focal lesion but has heterogeneous enhancement. You can see here there's soft tissue within the portal veins. On T2 there's no flow voids, and then on B-value pretty much the whole liver restricts on diffusion in this patient with infiltrative HCC. Here's another example of portal vein invasion. You can see the tumor thrombus extending out into the portal vein, and this is the primary tumor out in the left lobe that's growing down through the portal vein. This excludes obviously a patient from transplant, so portal vein invasion excludes transplant list. Here we go, arterial, there's enhancement here in the portal vein and then it washes out and it's bright on T2. So you want to look to determine the difference between benign bland thrombus and tumor thrombus, because bland thrombus does not exclude a patient from transplant, and it's important to distinguish those because once you call portal vein thrombosis, that patient is off the transplant list in essence forever. So arterial enhancement and washout within that tumor thrombus is very critical to distinguishing bland from malignant thrombus in the portal vein. Gadoxetate, EOVIS, and HCC. So we're about to come out with a new version of LIRADS, which is going to start including hepatobiliary agents in it. And I just want to go over a couple of findings. So obviously, hypointensity on the hepatobiliary phase suggests HCC because HCC will have fewer hepatocytes to take up the contrast. If you have a hypointense rim surrounding a lesion, that suggests hepatocellular carcinoma. If the lesion itself is hyperintense, that's not benign or malignant, because both HCCs and benign lesions can be hyperintense. You really want to use this rim surrounding a hyperintense lesion to suggest hepatocellular carcinoma. And if you don't see the lesion on the hepatobiliary phase, then that's really suggestive of benignity. So this you can use for benignity. For example, vascular shunts can be very troublesome. A lot of these LIRADS 3 lesions are vascular shunts. If you see nothing on the hepatobiliary phase image, you can sort of blow that off and move on. So these are the imaging characteristics for hepatobiliary phase imaging that will be coming out in the next year. Here's an example of an arterial enhancing lesion that becomes hypointense in the portal venous phase and is hypointense in the hepatobiliary phase. Here's a hyperintense HCC. You can see here on the arterial it's hyperenhancing, it's T1 pre-bright, and then on the hepatobiliary phase it collects contrast and becomes very bright, but has a classic hypointense rim surrounding the hyperintense nodule. So for focal liver lesions, I just want to hammer home, clinical history is really the most important thing in terms of distinguishing these lesions. There's a couple of key findings to differentiate lesions, and at the end of your syllabus I put in some sort of charts of differentials based on classic findings that may help you sort of tease apart different types of lesions. And then with HCC, I think LIRADS is really, really helpful to keep consistency of interpretation across sites so that when you're with your referring clinician, every time they get a LIRADS 5, they know what they're dealing with, and it helps create